Sometimes we can't tell. Sometimes all the testing we do is for these lymph nodes that are in the middle is negative. We can't always see them. They don't always light up. Not all the cancers light up. So sometimes we have to look inside with a camera, a special camera that goes inside the airway, and basically looks to see if there's any disease that's spread along the airways. Sometimes we do something called a mediastinoscopy, and I'm going to explain this a little bit more afterward, where we actually surgically go after those little lymph nodes that are sitting there and along the trachea, and basically pluck them out like little cherries, and have the pathologist look at them under a microscope to determine if there's cancer there. Less invasive versions of this, the endobronchial ultrasound I'll go through, and there's surgical staging, which we seldom do these days. We seldom do exploratory surgery in the chest. It's just not a nice thing to do to somebody, because you give them all the pain of having the surgery without actually treating them. So not a nice thing to do. So next, so just to go along with this, I hope nobody here is faint of heart seeing a scar, but this is basically what a mediastinoscopy does, and it's one of the oldest procedures that thoracic surgeons do. Make a little incision right here in the neck, and we slide a special camera right along the windpipe. And all of these little lymph nodes here, we just basically pluck them out and evaluate them. This is still the best test that we have for the mediastinal lymph nodes. It's virtually 100% sensitive for any metastases to those lymph nodes. Next slide, please. At Maimonides, we've come up with some better solutions to avoid the scar. And virtually in about 90% of patients, we're able to look at the lymph nodes in the mediastinum without ever making a scar on the neck. But we put a special camera, it's a special bronchoscope that winds down the airway. And these are lymph nodes outside the airway. And we basically, the tip of the scope has a little ultrasound probe on it, so we could see through the wall of the airway. And using ultrasonographic guidance, this is what it looks like. We stick a needle right into it, and we're able to sample it and get the same results. It's much better. It's something that I think we're the only center in Brooklyn that offers it currently, in terms of ability to stage it. In terms of ability to stage lung cancer. Next slide, please. So now that we have the staging, now that we've come to the conclusion that that little lung nodule is the only lung nodule you have, and there's no spread anywhere else, and we're able to do the surgery, and there's a good chance of cure, so what do? Well, we have the principles of surgery, is you have to remove that whole portion of the lung that tumor is in, because you have to remove that portion of it and encompass all the little lymph nodes in that area, because it's very important to get whatever areas that tumor has tried to spread to out. We try not to physically touch the tumor at all. We touch the normal lung around it. We try to preserve as much lung as possible. Everybody. If I took out both of everybody's lungs in here, nobody in this room would have lung cancer, but nobody would be alive. So we want to try to take out as little lung as possible to keep people going. And a lot of that is based on that lung function test that we do preoperatively. And to know how much we can get away with without compromising the cancer operation and without compromising your ability to live a meaningful quality of life. And also at the time of surgery, we also go after some of those lymph nodes. And that's just, we seldom are surprised by spread to lymph nodes in the mediastinum if we do a good job staging it beforehand. Next slide. So basically, here's a schematic of what your lung anatomy looks like. Here's your windpipe, right side, left side. Your right side, your right lung has 3 lobes. The left side has 2 lobes. The names are simple, upper, middle, and lower. Upper and lower on the left. And if the tumor is here, we have to remove this whole lobe. If the tumor is here, we remove this whole lobe. So on and so forth. If the tumor is here, we remove this whole lobe. Now, if the tumor is involving more than one, then we have to take out 2 lobes. And if the tumor is involving the whole main airway going to one side, the only conceivable way of treating it surgically is to remove the whole lung. People who have good pulmonary function in their reserve lung, they live pretty well without a lung. And it's just one of those, sometimes we have to do it. What's interesting is the lung is like a balloon. When you take out a portion of the lung,